Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. Moving on to Pes Cavus, this is someone who has a higher arch without reduction on weight-bearing x-ray. The deformity can be seen to occur at the hindfoot, the midfoot, or the forefoot. The etiologies, neurologic can be one of the major etiologies, can cause a muscular imbalance. This is well known in Charcot-Marie tooth disease. We have a situation there of weak extensors. The peroneal tendons overpower that, and the result is echinus deformity. Of course, myelodysplasia, poliomyelitis, Friedreich's ataxia, different neurologic dysfunctional disorders associated with Pes Cavus. 3 components to look for here: a high longitudinal arch. We can see that again with our calcaneal pitch angle. We can see the lateral first metatarsal talar angle. We can see hindfoot varus, AP-talocalcaneal angle, and even a forefoot and midfoot adduction angles, the AP talonavicular coverage angle or the first metatarsal talar angle. In assessing Pes Cavus, we're going to look at the calcaneal pitch angle denoted by the base of the 5th metatarsal head to the calcaneus, and then another line taking it up to the calcaneal cuboid articulation closer to the calcaneal side. In the situation of Pes Cavus, we can appreciate the elevated angle as the calcaneal cuboid line moves more superiorly. That angle widens in calcaneal pitch angle elevation, Pes Cavus. Looking at the lateral talar first metatarsal angle, we can appreciate the normal state of affairs where we have bisections of the talus along the first metatarsal. Notice in a situation of Pes Cavus with elevation of that angle, we can appreciate that the talar vector is more superior to the first metatarsal vector, and anything over 0 or definitely over 4 is going to be considered Pes Cavus. Looking at the AP talocalcaneal angle can be helpful in Pes Cavus. Again, we're going to bisect our talus and then take a lateral calcaneal sidewall angle, a line, and the angle between these 2 regions is the AP talocalcaneal angle, and that is noted to decrease in Pes Cavus. Notice that as the talus moves laterally, it decreases this angle with the calcaneal sidewall, and they become closer, and the angle decreases in a patient who has Pes Cavus. Other features that are not angular, we can see the see-through sign in Pes Cavus. In this sign, we can see the sinus tarsi supranormally, and that's something that we don't usually see in normal x-rays just so well, going right through the angle. We can also appreciate posterior fibular positioning and the double dome sign. The double dome sign is occurring because of the patient's need in Pes Cavus to rotate the foot and ankle so that the heel strikes and we have the ability to get into a stable position. So often Pes Cavus patients need to rotate the ankle in order to have a stable position, and that's seen through that double talar dome sign. Let's talk about the Hibbs angle, lateral calcaneal first metatarsal angle. This is a really important angle. It's important for us to see in Pes Cavus. It's been shown to be a reliable angle in assessing Pes Cavus. And for the Hibbs angle, it's the lateral calcaneal angle compared to the first metatarsal angle. And we can see that normally the Hibbs angle is greater than 130 degrees, and a Hibbs angle of less than that may indicate Pes Cavus. Let's talk about bunionettes. That's the varus angle that the 5th MTP is often making. And we can see that here as we bisect the 5th metatarsal and create the vector that gets the plane of the 5th, and along the 5th toe, we can understand that 5th MTP, that 5th MTP bunionette angle. And then, of course, there's an intermetatarsal angle called the 4th and 5th intermetatarsal angle. And that is often widened in more severe cases of bunionette. Looking at the first metatarsal angle, this is an important angle for us to understand how we're going to treat our patients who have hallux valgus deformities. The greater the angle, the more need for a derotational osteotomy. The less the angle, the more a hallux valgus osteotomy, a simple metatarsal tibial eminence osteotomy may suffice. But understanding these angles is imperative to understanding, will the patient go on to do worse if we just simply remove that portion of the tibial eminence? So greater than 9 is consistent with metatarsus primus varus. Another angle we can invoke is the midfoot overlap or the metatarsus adductus angle. And this can be difficult to measure in that we're looking to find the midpoint vector between the cuboid and a summation vector on the medial side between the medial cuneiform and the navicular. So we're going to drop that point and understand from the distal aspect of the medial cuneiform to the medial navicular, taking a line AB. Then we're going to take a bisection of that line C, and then a line E related to the second metatarsal will help us understand how adducted we are. So when we take E and C, we can get a degree of metatarsus adductus. Now, in looking at this foot here, we can see that there's quite a bit of overlap along the metatarsal region. And when I see that when the second and fourth overlap greater than 100% of the base of the third, I usually call metatarsus adductus even without the angular measurements, because there is a certain degree of overlap that occurs. So that's a shortcut. But generally speaking, this metatarsus adductus angle, complicated to obtain. Sometimes it can be difficult to see where the endpoints are to compare the medial and lateral column. But nonetheless, when you see the angular measurements, metatarsus adductus is a finding often seen in Pes Cavus. Looking at the Dijon-Annonay angle, it's defined as an angle by 3 specific points: the lower point of the calcaneus, the lowest point of the talonavicular joint closest to the talar side, and the impact point of the medial sesamoid. So together, this angle Dijon-Annonay, we can see less than 115 degrees in cavus foot. And usually it's between 115 and 135 is normal, and more than 135 is going to be seen in flat foot. Useful measurement. Are you ready to take your podiatric imaging skills to new heights? Check us out at RadPodSquad.com. Explore our online learning community. And don't forget to like and subscribe to our YouTube channel for more enriching content.